Hi, my name is Gabriel B.D. Sergio.
Hello, my name is Riley Craig.
Hi, my name is Sarah Jacobson.
Hi, my name is Brianna Fry.
My name is Emily Burnett.
And we are EBP Group 3.
Mia Jones is a 4-year-old patient who's here with her mother, Katrina, for a well-trial checkup and immunizations. Katrina has mentioned that she's very concerned about Mia's mouth. She says she cannot afford to go to the dentist right now, but Mia's starting to look thin and refusing any food that she needs to chew. She knows Mia is due for her immunizations, but really wants someone to look at Mia's mouth before anything else is done.
Dental caries in the United States is sometimes referred to as a silent epidemic. This is especially true in children and individuals living in poverty, such as Mia. In a study published in 2014 by Dr. Clark, a pediatrician, and Dr. Slayton, a dentist, in the United States, 25% of 2 to 5-year-old children from low socioeconomic and minority groups experience 80% of dental disease in the United States.
The clinical issue revolves around comparison of fluoride treatment versus no fluoride treatment in pediatric patients and determining its impact on oral health within a 1-year time frame. Dental caries, commonly known as tooth decay, remains as one of the most prevalent chronic diseases among children worldwide, leading to pain, infection, and impairment in eating and speaking. If untreated, caries can progress into an abscess under the gums, systemic infections, and if serious enough, can be fatal, according to a 2021 article about cavities by the Center for Disease Control and Prevention. Lack of dental care resulting in caries can also impact schooling in children. In a study published in 2018 by Professor Rabello and their associates at the School of Dentistry, the Federal University of Amazonas in Brazil, it has been found that children with dental caries are more likely to have worse school performance and attendance.
To avoid lifelong medical and social impacts of dental caries, preventative action is necessary. Fluoride has been widely recognized as a key element in preventing dental caries due to its ability to remineralize enamel and inhibit the demineralization process. The application of fluoride treatments, whether through toothpaste, varnishes, or rinses, has become a cornerstone of preventative dental care for pediatric populations.
The proposed project aims to systematically evaluate and compare the effects of fluoride treatment versus no fluoride treatment on oral health outcomes in pediatric patients within a 1-year time frame. By conducting a rigorous review of existing literature, the project seeks to address several key objectives: assessment of efficacy, evaluation of safety, identification of optimal practices, and informed decision-making in regard to the best oral health practices.
Our search strategy was as follows: the patient P, intervention I, comparison C, outcome O, time T, or PICO format was used to formulate the following clinical question. In pediatric patients, what is the effect of fluoride treatment compared to no fluoride treatment on oral health within 1 year? Patient defined as pediatric patients, intervention defined as fluoride treatment, comparison defined as no fluoride treatment, outcome defined as oral health, and time defined as 1 year. A literature search was completed using the Cumulated Index to Nursing and Allied Health Literature, CINAHL, and PubMed databases. Key concepts, synonyms, and abbreviations from and related to our PICO question were combined with Boolean operators and used as search terms. The following search strategy was used: pediatric patients or children, or minors, or juveniles, or infants, or kids, or peds, or pediatrics, and fluoride treatment, or fluoridination, or fluoride therapy, or fluoride supplementation, or fluoride treatment, or fluoride varnish, or FVA, and no fluoride treatment, or placebo treatment, or non-fluoride intervention, and oral health, or dental hygiene, or oral hygiene, or dental health, or dental care, or dental caries. Results were then filtered for studies published between 2014 and 2024 to ensure recent studies were viewed. The search yielded 64 results on CINAHL and 1,003 results on PubMed. The results from CINAHL were reviewed for relevance and application to the PICO question. One study was selected for inclusion and fully examined in the PICO summary grid. After evaluation of these initial studies, it was determined that the other options didn't answer the PICO question as comprehensively as was desired. Therefore, an additional study from CINAHL was selected once the search was expanded by using the following search strategy: fluoride varnish and pediatrics, or child, or children, or teen, or teenagers, or adolescents. This yielded 311 results after limiting the search to publications within the past 10 years. From these, the study was selected based on applicability to the PICO question. The results from PubMed were then re-examined and limited by applying filters to show only randomized control trials that had been completed in the last 10 years. This narrowed the search to 208 studies. After review of the first 30 results, one study was selected based on its relevance to the PICO question.
Our review of literature goes as follows. Mo Hammadi, an associate professor at the Department of Dental Public Health in Kerman, Iran, and his associates published a study in 2015 where randomized control trials were conducted to evaluate the effectiveness of fluoride varnish in reducing mean decayed, missing, and filled teeth, or DMFT, in children. A sample of 476 kindergarten children, ages 3 to 6 years old, were gathered from 12 kindergartens in Kerman, Iran. Children were enrolled into the study after their parents signed an informed consent, were educated on the nature of the study, and filled out a questionnaire which included demographic data and their child's oral hygiene habits. Children under the age of 3 or who were uncooperative were excluded from the study. The initial examinations of each participant were recorded using the International Caries Detection and Assessment System, or ICDAS. The system is divided into 6 codes and are recorded as decayed teeth, filled teeth, and posterior missing teeth due to caries. Only deciduous teeth were examined, and therefore examinations of molars or incisors that may have erupted in 6-year-old participants were excluded from the study. Additionally, anterior deciduous teeth were not recorded as a loss due to dental caries if they were missing. Following the initial examination, the control and test groups were divided in a way that would keep the children with similar oral hygiene habits, age, gender, and caries together. A varnish containing 5% sodium fluoride was applied to test groups by oral hygienists using a special applicator brush on dry teeth surfaces. The varnish sets when it comes in contact with saliva on the teeth. Proper instructions were given to the parents on what to do or not to do following the varnish application. The control group did not receive varnish or an intervention at this point of the study. A follow-up examination was conducted 3 months after the initial varnish application with the same examiner who utilized the ICDAS recording system as used before. Using the same application technique, both the test and control group received the 5% sodium fluoride varnish. 3 months after the second examination and varnish application, the groups were examined according to the same method as before, and varnish was applied again to both groups.
Mohammadi in 2015 concluded that the study showed a 14% reduction in the mean DMFT of participants in the control group over a 6-month period. The reduction of DMFT is more evident in the participants who received the varnish twice during the course of the study, compared to a systematic review carried out in the periods of 6 months to 3 years. Fluoride varnish was shown to reduce caries by 30% in deciduous teeth. Therefore, the result of 14% reduction for this study, taking in mind the time period of the study, is acceptable. The study demonstrates level 2 evidence implementing RCTs reduces selection bias by dividing the participants into test and control groups randomly. The study also established inclusion and exclusion criteria to provide consistency among the dental examinations. For example, molars and incisors that may have erupted in the 6-year-old participants were not examined in order to maintain continuity in all of the exams. The results that may have skewed if molars and incisors were included in the exam data, as not all children had these teeth eruptions. The study was strengthened with keeping the same examiners and hygienists who were also blind to the test and control groups of the study. The examiners and hygienists also followed the ICDAS system throughout the study and utilized the same application technique for the fluoride varnish. Additionally, the study established informed consent that the parents of the participants must agree to prior to the enrollment of the study.
Although there are some factors that vary amongst the participants, the study determined that fluoride varnish application has been shown effectiveness in reducing DMFT in children between the ages of 3 and 6. Some factors that may impact the study include hygiene practices, genetics, adherence to the education provided, and history of dental care. The study aimed to randomly assign participants to test and control groups where participants had similar backgrounds to better assess data. Overall, the study demonstrated the benefits of fluoride varnish application in reducing DMFT, which is consistent with the results found in similar studies. Dipali Agarwal, a researcher with the Center for Dental Education and Research in Rohtak, India, conducted an RCT with his associates in 2022, determining the effectiveness of fluoride varnish to prevent dental caries in children. This study was conducted in Angawadi centers and schools for the Rohtak district in India. A lottery method was used to create 2 groups, intervention and control, of 256 children that were 3 to 4 years old. Children were permanent residents, not likely to migrate during the study period, and had a high caries risk. Any history of a fluoride allergy, taking long-term reactions, having systemic diseases, congenital anomalies, reduced mouth opening, stomatitis, or gingivitis were excluded from the study.
Fluoritop SR was applied to all teeth in the intervention group. Teeth were first dried and plastic brushes were used to apply the fluoride varnish on all erupted teeth. The caretaker was then instructed to ensure that the child avoided drinking liquid for 30 minutes and avoided solid food all day. In the control group, teeth were painted with plain water. This application process was done at baseline, 6 months, and 12 months. Examinations were done using the ICDAS criteria. A trained dentist who was blinded to the group assignment examined each participant using visual and tactile inspection with a mouth mirror and ball-ended explorer. A calibration for diagnosing dental caries was done with providers prior to assessing study participants. Additionally, 10% of the study population was randomly selected to be re-examined in an effort to ensure reproducibility. Caries increment was used to determine the primary outcome of the study and was measured at each time point. The increment was counted if the surface status changes from sound or filled at baseline to first visual change in enamel, missing due to caries extraction, or stainless steel crown. Any improvement in caries was subtracted from the increment, resulting in a net caries increment value.
Throughout the study, there was a large dropout rate, primarily due to migration, dropping out of school, non-willingness to participate between the study period, and loss to follow-up. Children that did not attend their appointments and/or could not be reached after 2 phone calls or visits were considered lost to follow-up. Due to this, 196 participants from each group were included in the statistical analysis. There was a significantly decreased increment in mean ICDAS score between the experimental versus control group at 12 and 36 months. Additionally, those with at least 1 or 2 applications of the fluoride varnish showed a significant reduction in new caries lesions in the experimental group versus the control. There was no statistically significant difference between the groups after the 3rd varnish application.
With this study, Agarwal showed that fluoride varnish applications will reduce the number of dental caries in children. There is also some indication that increasing the number of applications beyond 2 may not provide any additional benefit to children. These results are limited by the difference in baseline caries in children. There was a significant difference between mean baseline caries in the experimental and control group. To avoid this limitation in the future, adaptive randomization can be used. Given the high dropout rate, a more intensive follow-up protocol can be used in the future to prevent dropout. An additional factor that may also assist with this is to study biannual varnish applications instead of quarterly. Given the cluster randomization, the participants were representative of children that were part of the Rotok community through Anguinati centers and schools. Researchers still systematically selected clusters and participants within each cluster to be involved in the study, which limits how representative the sample is to the community as a whole. In addition to this, children that did not attend school, had parents that didn't consent, or had confounding medical concerns were excluded and therefore limited the generalizability and representation of the study. There was no significant difference between study groups for gender, parental age, socioeconomic status, frequency of brushing teeth, types of toothpaste used, or sugar score. This study also represents level 2 evidence and is strengthened by the use of inclusion and exclusion criteria. Official registration with the Clinical Trial Registry, India, or CTRI, following consort guidelines for randomized controlled trials, utilizing informed consent processes, and implementing a double-blind design.
Dr. Patricia Braun, who has a master's in public health and is a professor of pediatrics at the University of Colorado School of Medicine, and her associates conducted a quasi-experimental oral health promotion, OHP, evaluation over the course of 6 years to determine the impact of special OHP interventions on mitigating the prevalence of early childhood caries, ECC, published in 2017. At different stages during the course of trial, 3 unique cohorts of children aged 3 to 4 years old were given an oral examination at 8 participating Denver Health federally qualified health centers, and oral health was quantified based on the number of decayed, missing, and filled tooth surfaces using a zero inflated negative binomial models. The OHP training provided to the participating medical providers included an oral examination, ECC risk assessment questioning, dental referral, and fluoride varnish application. This training was developed by an interprofessional team in 2008, just prior to the study, and established a standardization for FBA oral exam and education.
Inclusion criteria for participants included being 3 to 4 years of age, having had at least 2 previous Denver Health facility visits, with at least 1 visit in the past 18 months. Data was gathered and statistical analysis was conducted on participants, who were examined by trained dental examiners through the affiliated Denver Health facilities. Descriptive statistics were calculated to describe all study outcomes and evaluated using chi-square, Fisher exact test, and Kruskal-Wallis test to assess significance of findings between all cohorts. ECC prevalence among the cohorts was evaluated by maintaining independent variables of child age, gender, ethnicity, insurance, caregiver's education, number of children in the household, presence of a caregiver or family member with recent cavity, and 8 defined oral health behaviors. The dependent variables were limited to the decayed, missing, and filled tooth surfaces, DMFS, and decayed surfaces, DS, in deciduous dentition. The results of this study found that from the pre-intervention cohort to the mid-intervention cohort, there was no statistically significant difference in dental experience, DMFS prevalence, or DS prevalence, with a mean FVA at given well-child visit, WCV, of 1.1. However, the study did find that compared to the pre-intervention cohort, the final cohort in 2015 that had a mean FVA of greater than 4 had a statistically significant decrease in DMFS prevalence and DS prevalence. Overall, from 2009 to 2015, adjusted ECC prevalence decreased by 16%, and adjusted in untreated ECC decreased by 28%.
Limitations found in this study were the quasi-experimental design and the lack of a true control group. Fortunately, data between cohorts was analyzed using multivariable regression as opposed to univariable comparison, which strengthens the validity of the findings. This study represents level 3 evidence. This study adequately manipulated independent variables, but by nature of the experimental design, failed to randomly assign experimental and comparison groups. As a result of the non-random experimental groups, this study was unable to account for secular trends between cohorts. However, a strength of this study is that the comparative analyses were conducted from previous trials examining the efficacy of FVA conducted by the U.S. Preventative Service Task Force in 2014, but were now extended to include FVA performed by non-dental providers in real-world settings. Ultimately, Braun and his associates determined that increasing OHP through standardized interdisciplinary education and training led to better OHB and increased FVA in early childhood, which decreased the prevalence of ECC. These are applicable findings to the field of public health by way of promoting communication between medical and dental providers to allow children to receive at least 4 FVA before age 3.
Throughout the world, fluoride treatment has been explored in its efficacy in preventing dental caries, specifically among the pediatric population. The 3 key studies previously outlined provide insight into the impact of FVA and oral health outcomes in children. These studies were completed in varying areas of the world, but collectively emphasize the significance of FVA in education as an intervention measure against dental caries and an increase in oral health in the pediatric patient population. More global research would be required to ensure the generalizability of the studies. Based on the literature review, each study concluded that at a minimum, 2 fluoride applications should be given to children at risk for dental caries. While further research can be done to advance the understanding and standardization of FVA protocol, the evidence that has been collected suggests that it has an important role in promoting oral health and decreasing the prevalence of dental caries in children worldwide. Additional research should also be conducted to assess the long-term implications on oral health between children that receive fluoride varnish versus those that do not. Studies conducted over the course of a 6-month to 6-year timeframe with evidence-based research support that fluoride varnish will improve overall health.
Understanding the comparative effectiveness of fluoride treatment versus no fluoride treatment in pediatric patients is crucial for clinicians, parents, and policymakers to make informed decisions about preventative dental care strategies. It can help address concerns regarding fluoride safety and inform guidelines for its appropriate usage in pediatric dental health. With a better understanding of how caries can be prevented, policies and interventions can be implemented in different areas to ensure children are receiving the treatment needed. The use of fluoride treatment is predominantly associated with dental offices. Establishing a systematic protocol within pediatric primary care settings, wherein an RN is properly trained to provide oral care, can enhance the accessibility of oral health services for children. This initiative aims to bolster the provision of consistent oral care, thereby mitigating the incidence of dental caries among pediatric populations. The proposed initiative entails training an RN to provide oral health care within a pediatrician's office on a recurring basis, with the aim of delivering comprehensive oral care to patients identified through screenings conducted by registered nurses. The multidisciplinary healthcare team composed of pediatricians, RNs, and office support staff will collaborate to develop a survey to assess parental interest in employing oral care services during office visits. Parents expressing interest in their child receiving oral care while at the office will be required to provide consent, following which their child will undergo screening by an RN.
Ensuring the RNs are adequately trained in oral health status assessments will be imperative. Subsequently, if the RN determines that the patient meets the eligibility criteria for oral care, they will inform the patient or caregiver about the services to be provided by the RN, facilitating informed decision-making. This structured approach aims to enhance the accessibility of oral health services and promote optimal pediatric oral care within the primary care setting. Upon verification of the parental/guardian consent form, the trained RN will proceed to administer oral care for the child. The RN will meticulously document the child's baseline oral health status to ensure accurate and standardized assessment using a validated tool such as the ICD-AS. Application of a 5% sodium fluoride varnish to the child's dry teeth will be conducted by the dental hygienist utilizing a standard applicator brush. Following the varnish application, both the dental hygienist and the RN will provide detailed instructions to the parent and guardian regarding post-application care practices. The RN will diligently record pertinent details including the survey responses, assessment outcomes, consent documentation, baseline oral health assessment, and varnish application within the patient's medical record. This meticulous documentation process aims to uphold accountability, facilitate continuity of care, and enable comprehensive tracking of oral health interventions for pediatric patients.
Data collection will span a 2-year duration, during which feedback from parents and caregivers regarding their experience will be systematically recorded to monitor satisfaction levels throughout the initiative. Additionally, feedback from patients or their guardians will be collected and reviewed at the 1-year midpoint and upon the conclusion of the 2-year period to assess the necessity for modification in assessment protocols to enhance patient satisfaction. At the culmination of the initiative, the healthcare team, composed of the dental hygienist, pediatrician, RN, and office support staff, will undergo a comprehensive survey to gauge their perceptions of the initiative's overall success, utilizing a Likert scale for rating. Oral health assessment data collected from patients at the 1-year and 2-year follow-up appointments will be compared to baseline assessments using the ICD-AS scoring to determine effectiveness of the fluoride varnish in preventing dental caries.
The insights gleaned from the 2-year initiative will be instrumental in determining the necessity for modifications in the program structure and format, as well as informing decisions regarding its continuation. This systematic approach aims to foster evidence-based decision-making and ensure the sustained efficacy of the initiative in optimizing pediatric oral health care within the primary care setting. The following recommendations recommendation is an evidence-based approach to preventing dental caries and would greatly improve the oral health of children such as Mia Jones, given the cost effectiveness and accessible nature of the proposed intervention.